Good afternoon, everyone, and welcome. Thank you so much for joining us today. I'm Samantha, and I work as the Director of Member and Partner Services of ACOs. We are very, very excited today to present to you with our next installment of our free webinar Wednesday series with our business partner, PointRight. Today, they're going to bring to you how ACOs can achieve better cost savings and post-acute quality outcomes through analytics. We are joined by Sharon Fisher. Sorry, I have where'd it go? Sharon Fisher is a senior healthcare executive who has specialized in bridging partnerships between acute and post-acute health systems and preparation for episodic care management and positioning for value-based payment models. As PointRight's Chief Development Officer, Sharon has led the organization's growth strategy and collaborates with stakeholders across the healthcare continuum to drive down costs and improve quality through workflow efficiency and data transparency. She is very proud to work alongside some of the industry's brightest minds who share a common mission to enhance the lives of those we touch. Thank you for being here, Sharon. I will also introduce to you John Bick, who is the Senior Director of Market Operations for Best Care Collaborative, a next-generation ACO in Fort Myers, Florida. John has been with Evolent Health since January of 2018, and he has 25 years experience in healthcare. He began his career as an oncology nurse in Indiana, and over his 17 years in health plan administration, including medical management and provider contracting with various organizations. John obtained his Bachelor's of Science in Nursing from Indiana University and also a Doctor of, I'm not even sure about that one. John, can you tell me where that's from Indiana?
Doctor of Jurisprudence in law. It's a law degree.
Thank you so much. He was previously admitted to the Indiana and Georgia bar. Before I kick it over to Sharon, I do want to go over a few housekeeping notes this morning. You should see an attendee interface on your computer desktop in the upper right-hand corner. You can listen in via your computer speakers, or if you would prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during this presentation. I will collect these and address them during the question and answer session at the end of today's presentation. Again, Sharon, John, thank you both for being here, and we look forward to your presentation. You there, Sharon?
Hi, I lost you for a minute. Are you there?
We are here. We're ready to go.
Terrific. Thank you, Sam, for the introduction. And it was also a privilege to attend and as well as be a co-presenter on a panel at your annual conference just a couple weeks ago. A lot of great energy and encouragement for the space that we are navigating with ACO and value-based and taking risk and really trying to strive for quality improvement from many different disciplines, and it's encouraging to see the good work that you all are doing. So thank you for having us, and I'm very excited to have John join us, who's a new client as Best Care Collaborative with PointRight, and since they're based right here in Florida, I thought that would be nice to hear firsthand of kind of where they are in their journey, and so we'll be interacting between John and myself throughout this afternoon. There are three key things that we're hoping as objectives for today's session. The first is really understanding a little bit more about how analytics can help an ACO do three things: build, monitor, and manage high-performing skilled nursing center networks. And the second is to perhaps learn a little bit more about a different type of data source, which is a clinically structured data called the minimum data set, and that abbreviation is MDS, and how this data set can actually help complement some of the claims data that are most commonly used and are currently available to ACOs. And then we talk about why structure doesn't matter, whether you're putting your toe into bundle payments or if you're a physician ACO, a hospital system ACO. It really doesn't matter where you are in your journey. There are places where PointRight and looking at the power of this type of data can be leveraged throughout your organization. So a little bit about Point Right. We've been strong advocates in the post-acute skilled nursing space for over 20 years, and the use of the data that the skilled nursing centers use is able to provide us the ability to create predictive as well as looking at descriptive analytics to then be able to bring you predictive analytics to stay out ahead of any trends or negative trends and get out ahead of negative trends before they even happen. So within our platform, it really helps to give a 360, a full view of your long-term and post-acute, which is LTPAC, as we know, performance, facility level performance, as well as patient level clinical insights. So those two pieces are what we're going to focus on today. The first piece is going to look at facility performance, and then we're going to move into the clinical insights. I thought it might be helpful just to see some of the other health systems that are tackling similar things as you, and we have 3 current clients right now in Florida that are at different phases of network development, but all doing a great job. So when we start to look at network performance, we thought it'd be helpful to understand, kind of the framework that we have designed at Point Right and are now seeing real sustainable success from them. And the key thing is, without the right data, many folks have told us that they have blind spots, especially blind spots post-hospitalization. And there's nothing worse than going down the wrong rabbit hole, thinking that you're onto something, and because of the historical nature of the data, it may not be actionable today to correct the wrongs of yesterday. And John, if you want to spend a couple of minutes on how you're looking at different data sets to kind of put your program together, I'm happy to have you share your thoughts around getting the right data.
Yeah, absolutely. We, as a next generation ACO, of course, we get a really pretty complete data set from CMS regarding claims data on our skilled nursing facility partners. And in this space, the how you develop your preferred network is really key, because there's a big carrot in the next generation ACO model if that ACO is approved to use it, and that's the SNF 3-day waiver. So you want to make sure, if you're going to funnel additional patients into these facilities, that without having that 3-day stay in an acute care facility, that you have the right partners. Now, claims data tells you a lot about that facility. It will tell you what their average length of stay is. It'll tell you their readmission rate. So you get some decent information around claims. But what you really don't get any insight at all into is what happened to the patient while they were in the facility. And that's the key piece of information that we are using the Point Right data for, because it'll give you the QM facility information around what their pain level was like, their pressure ulcers, how they improved in function, or did they improve in function, pneumococcal vaccine. So you get a lot more data through the MDS data sets about the patient that you just would have had no idea whatsoever about. So it's really key in combining those two data sets, the historical claims from CMS and the Point Right data, that gives you an insight into what actually occurred with the patient while they were in the facility. So it's an invaluable tool to develop those relationships to make sure, since we are at risk for not only the patient's cost of care, but also the quality of outcomes of their care, that you have the right partners.
That's great. Adam Buhler from CMMI talks frequently about the success criteria and some of the pillars that they focus on whenever they're going to launch a new CMMI initiative. And there are three pieces, and we take this, we carry this across as we're building out high performance networks, as well as monitoring and managing them. So one is looking at the ability to have transparency of data and the performance, and so that everyone is looking kind of at their same scoreboards together and understand that there's a common thread of data understanding of the data. And then simplicity, how do we reduce the burden and focus on the things that really matter? So many folks approach myself as well as John about you can get data paralysis. There's so many different metrics coming at you. How do you know which ones really matter and which ones to focus on that can really help to move the needle? And then how do we hold each other accountable? There's reimbursement rewards for our outcomes, and so if our efforts aren't aligned to hit those outcomes, then we don't win as a team. So we carry those themes over in our framework as we build the post-acute networks, as we look to monitor both at the network level and the ability to monitor at the individual SNF performance. And then as we move into managing the network, we can see how the progress is improving at both the network level, and we can also manage at the patient level, which requires a couple of different things. So the first piece, when we're actually building the network and using PointRight's 360 scorecard, then it gives you the ability to do a few different things at your fingertips. So you help design where your geographical circumference, whether it's by a hospital referral region, by zip codes, by the HSA, by county, you pick and choose your performance radius that's important to you. And then those SNFs will come up in that area. It also gives you a very easy dashboard to look at the 7 domains that you can start to monitor. And each of those trigger into rehospitalization, the clinical quality performance. We even include 5-star as a way to start to gauge what is the performance look like. And when we do this, as you look at your overall network, once you've picked that geographical area, then you can say, are there unique things happening in this market that may be different than what's happening in the state or in the nation? So having an understanding of that right out of the gates is really, really helpful. So as a whole group, your comparison group as a roll-up, what is their current state of rehospitalization? And I would highlight for you to really look at the risk-adjusted components. So where you see group hospitalization rates observed and then the adjusted, these risk adjustments are critical because it helps to identify, it takes everything out and helps the SNFs then become, have the ability to be measured against each other. So there's a way in which by risk adjusting, everyone is now on the same playing field. I usually share that the only thing 2 nursing centers in the same market have in common is a license to be a nursing home. But the populations and the patients that are coming through there can look very, very different. So if you just take raw data in from each nursing home, it doesn't show and doesn't give credit to those that are doing a really good job with very complex patients and or those that are taking maybe the less complex patients and maybe they're not doing a great job with them. So how do you even that out? And our risk adjusting models do that for us. Those risk adjusted models, the PointRight Pro 30 has gone through the NQF endorsement program or process, and so it has now become a industry model to use, and is also used by the American Healthcare Association and many other organizations as the standard way to measure rehospitalization. And again, once you have common definitions of how everyone is agreeing on how they're going to define rehospitalization, that's you're moving now into the right direction. Same thing on length of stay. If you're just taking in length of stay data from the SNF, some SNFs will include length of stay of people that expired and people that didn't. Same thing on rehospitalization. Some may report in the planned and unplanned. Some may just report in the unplanned. So having a consistent way to be able to measure one SNF against the other is critical. It also helps you to start identify at the facility level who's doing well in certain clinical conditions throughout your network. So it's good to know as an overall roll-up what that observed and the adjusted rate may be, but it's also critical to understand how are they doing compared to their peers when it comes to things like staffing or regulatory compliance or things like clinical conditions like COPD or heart failure or diabetes. We give the skilled nursing centers a grade for each one of these based on the median of that comparison group. So if you get a C grade, you are right on par with the median of your group. If you're an A or B, you're outperforming your peers. And if you're a D or an E, then there's work to be done and you're underperforming. So at a snapshot from an ACO or a health system, you can very quickly start to filter out who's already doing well within my comparison group and where do we have some work that needs to be focused on. John, anything else that you want to talk about on how you're using your scorecard today and what any learnings that you all are gaining from that?
Well, in particular, the adjusted rate, because there is a wide variance. Having worked for a large skilled nursing facility company in the past, there's a lot of decision making that goes into the discharge plan from an acute care facility that doesn't necessarily have anything to do with the facility's quality. There are other decision points in how that goes. I think everybody who's worked in that industry understands that. But at least in your partnership with the skilled nursing facilities that you want to pursue, you have this information. You may end up including a facility that is a little lower performing in your network for other reasons, but at least then you know what you need to work on with them. It could be for the purpose of filling a geographic hole, for example, or just a local political condition, whatever it entails in that decision making, but at least you have this data to know how closely you need to follow those admissions in that facility in order to start bringing their quality up. So the risk adjustment piece here is really valuable.
That's great. And one of the traps that many health systems have gotten caught in, because they only had the data that was available to them, many folks use 5-star ratings, and sometimes they use an overall 3 as a cut point to be opt-in or out. Many times we find that someone may be a 5-star or a 4-star overall performance, but they may be underperforming in some of the clinical conditions. So if it's a network that has a high population of pulmonary, complex pulmonary patients, and they blindly are using 5-star as their gateway to say if they're going to be accepted to the network, and that center that they brought in maybe is underperforming in pulmonary or COPD, they may not be the right center to be included. Or, as John was talking about, how do we partner together and collaborate to bring them up from maybe their average or median, hit the median at a C, how do we get them from good to great? So we include 5-star as a as a measure to compare things with, and it's there just because 5-star is not going away, but it can be limiting if you only use it, and you can get yourself trapped and the needle may not move as quickly as you need it to if you're only using 5-star. So just a couple of quick takeaways of what we've seen around when building out these networks is the ability to identify those post-acute centers that offer the best partnership value in the clinical and quality measures that are important to your organization. And then also the ability to see true current comparisons from one skilled facility to another. That's using that risk-adjusted Pro 30 measure. And then also avoiding any of the traps that you may get by some current data that's available. So once you identify who you're going to have at the table for discussions and invite them into the network, the next piece is to, and I should mention that the build part, that data that we are able to have in the scorecard is available without having to ask the nursing homes for any data. So if you are just curious around what is the current performance, even if you already have a network in place, what does that look like? We can help you, we can give insights to any skilled nursing facility throughout the country with all of those different features and functions of the Point Rate Pro 30 scorecard. So that's available to you just to take a look, and maybe there are some other SNFs that you hadn't thought about. Sometimes folks come to us and say, you know, we really try to narrow our network in, and actually we help to sometimes broaden the network, and that's why we look at more of a high performing network versus narrowing the network. Think about it being a real smart network that's going to hit the levers that your organization needs to advance and to hopefully be rewarded financially for all the good quality work that's happening. The next piece, though, once you identify the network, is then to, we then become, PointRight becomes the data partner, your analytics partner, and aggregates clinical data set called that minimum data set from the skilled nursing center, and we bring that in to a visual. We aggregate their data for you on your behalf, and then that's then displayed back, and we're going to show you a picture of what that kind of looks like. I just want to spend a moment though on this minimum data set because it is unique to the skilled nursing home industry. It's actually one of the best things that, as a federally mandated CMS has created, every nursing home in the country must fill out the same assessment, and it's about 43 pages long with over 500 fields of data that it gives the most comprehensive view of the care plan and the nuances of that individual patient than any assessment that exists anywhere else in the health system. So it's a really nice, you know, it's structured data, it's consistent, and then skilled nursing centers must it's already in their workflow. They have to complete this and submit it to CMS in order to, that's what sets their rate and their payment. So our role is we help on the back end directly with the skilled nursing centers to ensure that the best quality and validation of that assessment. There's some real-time tools that happen to give the skilled nursing center feedback quickly on the clinical connections that may be under coding or go back and defending why you're choosing to code a certain way. So when that goes to CMS, it's the cleanest assessment that, and the quality of the assessment is at the highest level it can be. Once that is done, then that data gets sent to electronically right from the EHR over to PointRight. And the cool thing about this MDS assessment is that it's happening in different intervals during the patient's stay. So upon admission, and then within the first couple of days or first week that they're there, and if there's a change in their condition, there's another one of these assessments done. If they're discharged back to the hospital, another assessment is done. So each time these assessments are done, we update those, which allows you to have very current data. And when you have current data, you can take action on that data right away. So now, as that data comes in, we aggregate that up for you and put it into a visual to do a couple of different things. All of your key performance metrics are mapped out by clinical condition and we break it out by all payer and Medicare. And then we rank those nursing centers on their performance by each of those clinical conditions. We also, and we weight each of these categories with you and give some cut points of gradients on what percentage are your targets. So anyone looking at can quickly see if it's in green, those nursing centers are within the zone that you're trying to shoot for. If they're in yellow, they're kind of the middle of the road. If it's in red, they're underperforming. And what's not uncommon to see is sometimes folks that are, and you can see it on this diagram, even on the first or second line, look at the third line. This facility is doing a really good job on their adjusted overall Pro 30 rehospitalization. But if you start to look at across the line at CHF, they're 10.9% readmission rate, which is fantastic. Pulmonary COPD, they're up at 25%. So this gives you a very quick snapshot as you're starting to look at the populations that are important to you on how is my network performing overall and who's contributing, where are some best practices in here, and where are there some common themes throughout the network that we need to work on, and or are there just a few that's bringing us down? So this gets rolled up for you. This is very powerful on a behavior modification, if you imagine, and many of you are working with physicians and your own scoreboards and scorecards but when you start to see peer-to-peer information being shared, this is where the transparency really starts to be a game changer. Everybody wants to be number one, and only one center can be number one at each of these sections, which is why we then put the gradient in. But we start to, we really encourage folks to anticipate getting comfortable being uncomfortable. But by the third or so month, as they start really looking at this data collaboratively, the ACO partners and the hospital partners and the physicians and the skilled nursing centers are all together sharing this. This is where the magic starts to happen. And as uncomfortable as it can be initially, it's the only way to really get into problem solving and root cause analysis and moving the needle for process improvement.
Yeah, and Sharon, this is John. Just a quick point on the MDS assessments and how technically they are done. It is typically an MDS coordinator at the skilled nursing facility who does these assessments. So there is a fair amount of consistency in how these are done. So it is actually, as much as a clinical assessment can be consistent, because the joke I tell myself all the time, you get 10 lawyers in a room, you'll get 10 different opinions, and they'll argue about them all day. Clinicians aren't all that different. You can have different views of what that patient's condition actually is, but the MDS assessment has a way of, with the instructions that come with that assessment, of leveling that variance out to the degree possible. So these are actually pretty good data points from a consistency perspective to be able to look at comparisons across facilities.
Excellent. Thank you, John. So just a couple, key takeaways on the managing of the net or monitoring the network. It helps to identify what's the capacity of the network, what are we doing well with, which facilities are contributing to my high performers, where do we need to put some extra work, and it really starts to look at the population outcomes and trends. We're able to monitor that at the network and at the facility level. So as you start to look at population health management, the next phase that folks then move into is to be able to managing risk at the patient level. So now this is a sample of a tool that both the ACO has a view in, as well as the skilled nursing center. So they're both sharing, using the same tools and looking at the same patients. I will share with you for PHI protection, the ACO typically sends us a patient or a member file. We we scrub that against your preferred network. When your nurse navigator or physician or nurse practitioner logs in, they only see their panel of patients. At the skilled nursing center, they see all their patients. So it's nice. Process improvement and the ability to look out ahead and get out and using predictive measures and analytics to take action right now, the skilled nursing center is able to do on their whole population. The ACO then would be looking at their panel of patients and being able to have that dialogue with the skilled nursing center as things are happening right now. So what you're seeing on the screen is just a sample of this tool called Radar that we use the red, yellow, green to show levels of impairments and degree of impairments. You can sort these kinds of things, and then we also rub the descriptive scales of looking at ADLs and cognition and mood and pain, and the arrows mean if they're improving or they're declining since their last assessment. And then PointRight has very rich predictive models that sit right next to it. So based on their current condition, how likely are they to have a pressure ulcer, or what is their likelihood of mortality? And then you can start looking at who's at high risk for mortality, who's at high risk for hospitalization, and perhaps they're not on a hospice or a palliative program at this time. Getting those early conversations in is a key. It improves customer satisfaction. It reduces unnecessary trips to the hospital. All that kind of goodness can happen. The other tool, the piece that this for is to demonstrate appropriate discharge planning so that we have safer discharges back to the community. And there's this whole complexity, discharge planning complexity. The higher the number, which is the very last column, the higher the risk. It doesn't mean it's impossible, but it drills down when you click on that of all the things that would need to be taken into consideration to safely prop this person back up into the community. And this comes into a one-page view. It's not the easiest to see here, but we're happy to set up a one-on-one demo or such and walk you through this. But one of the sections, for example, is on what is the risk of them returning to the hospital or the SNF. If they're a medium impairment, what does that mean? And what are the things that we should be keeping our eye out over the course of the first 10 days, 30 days, and many of you are now in risk-sharing modes beyond 30 days, out to 90 days, or even further. So we look out over a course of a full year, and these would be things, if we don't keep our eye on these could be risk factors that will bring this patient back into the health system. So sharing this with your PCPs, sharing this back with the ACO, sharing it with home health, community-based organizations, it helps to transition this patient a little bit safer back into the community. So we're managing, the three takeaways around this is that using this real-time, very patient-specific clinical data can identify gaps that maybe exist today, how to get out ahead to be proactive with interventions, align the right resources to the skilled nursing home at the right time. That's a huge piece. You may identify that the skilled nursing center's issue is not something that the nurse practitioner needs to handle. Maybe it's more of an education. If we see pain, for example, really flagging, maybe we bring in a pharmacy consultant or use other disciplines to come in and support training at the center, which keeps total cost of care down, especially if you can understand what needs to be done to prop up the patient safely at home. You may be able to shave off a couple days of SNF stay, or it may make more sense to stay another day or two in the SNF, and then you'll have a safer discharge and keep them out from bouncing back to the hospital. So it really gives you some safeguards as you're transitioning through the continuum. I thought it would be good to also share with you a couple of ways in which some of our health systems that have had great success have leveraged the ACO quality measures that you all are accountable for right now and how this clinical data combined with the claims-based data can address at least about 6 or 7 of those measures that you're faced with on your scorecards right now. So, and we can go into more detail with you specifically, but it is nice to see that this combination of different data sets can all be linked and drive to outcomes that you are and goals that you're setting for yourselves to be able to hit a higher scorecard within the ACO quality measures that exist today and that have to be reported out and are tied to financial incentives, of course. One of our clients is in New Jersey, and this was a really nice to see. We're now in our 3rd year of working with this organization, and they've been able to show incremental growth year over year. So to get a 13% reduction in post-acute care cost was a huge goal for them to be able to realize. And you know, it didn't happen overnight, but it also is showing a sustainable track record. So when they first started working with us, their average annual per beneficiary cost was over $1,000. And by the first year, they got that down to $918. By the second year, and they had a 14% decrease in SNF days, which was great, and a 13% decrease in the cost, which is fantastic. They were able to save $6.6 million. The first year, they missed getting a check cut, though, by just a few. But in the second year, they drove it down by $580 to $585. So it was a 44% decrease, and they were able to also have a check cut in the tune of about over $3 million for this particular hospital, and throughout their whole health system was over $6 million. So again, it doesn't happen overnight, but incremental growth improvements keep everybody excited, and they're not done yet by any means. So it is possible. You know, I like what I heard a few weeks ago about you know, start small. You know, you don't have to go after all the clinical conditions, but identify where some of your weak spots may be, where you're doing things that are looking really good. Take those that are doing a great job and make them even better together. And where you have weak spots, you now can take the blindfold off and attack it together. At this time, John, if there's anything else that you'd like to add, otherwise we can open it up for questions on some of your next steps that you're taking with your network.
Some of our next steps, we're in actually our first performance year. So we are just getting the first real actionable claims data from when we implemented our benefit enhancement back in April. So we're just really starting to see what those trends actually are at a facility level, and so really this is more for the strategy for ongoing network development in 2019 for us at this point.
Terrific. Sam, I'll open it up to you on questions from the group.
Okay, perfect. Thank you so much. Besides hospitalization, what else can you report on in the network performance report? Can it be modified to fit my organization's needs?
Yes, so the key performance metrics are fairly customizable, if you will. We typically look at some of the top ones that are most frequently asked of. That we include our rehospitalization by clinical condition. We also include length of stay by clinical condition. So you have that. It's nice to see both of those next to each other because you don't want to react to one without looking at the other. We also include quality measures for short stay as well as long stay populations, if that's important to you. We look at staffing. So there's many metrics that we can look at. If there's something really specific, then the great thing about the MDS data is there's so many different data points. If there's something that you're really trying to drive for, we can pull that up and look at that a little closer. Some folks have been asking us about sepsis, for example. but one of the kind of leading indicators of sepsis, one of the things that we identified at one of our networks that they were able to rally around was decreasing the use of enteral catheters. By decreasing use of those, it had the output was decrease of sepsis. And sepsis is the diagnosis that happens at the hospital, but it's not necessarily happening at the skilled nursing center. So it's really important to look upstream of what's causing these things to happen, and we can get very granular with you at the SNF at the facility level. Does that help?
Perfect. Yes. I have one more question. Does a nursing home have to be a customer for me to be able to get this information?
The nursing home does not have to be a customer for the first phase of the giving you that directional build of looking at the SNF, the Point Right 360 SNF scorecard. They do need to be a client when we bring in their data, and we typically do that in conjunction with the health system or the ACO, such as Best Care Collaborative. They announced to their network that they've chosen Point Right to be their data analytics partner, and then we work collaboratively to bring the data in on behalf of the network.
Awesome. Thank you so much for that.
Mm-hmm.
Is there anything else that you would like to add today?
I don't think so. Happy to take on any of the ACOs that are anywhere in their journey, even if they just want to make sure that they are picking the right one, picking the right skilled nursing centers. We have a lot of training support here at Point Right, some terrific clinicians that are in the field every day, battling the same challenges that you are. So happy to take any additional questions. If there's a visit or a demo that someone wants to go deeper, we can line that up after the call as well. So we are here for you.
Thank you so much for that. And thank you again for your time and John's time as well. We really appreciate it, and definitely, from John's perspective as well. So thank you again for that. And once you all exit, you will receive a survey on this presentation. We would really appreciate it if you would take the time out and complete and provide your feedback. We will also be sending an email with contact information if you have any follow-up questions with Sharon and or John, and a link to the recording webinar. Please feel free to share this with anyone that you think would be interesting, and watch your emails for upcoming webinar announcements. We hope you have a great day, and happy Thanksgiving. Take care, everyone. Bye.